Hi, everyone. I'm so glad you're here. We have coming to the virtual stage Vicki Keller of the California Department of Public Health, presenting her session, Infection Prevention Assessments and COVID-19.
Hello, California Skilled Nursing Facilities. My name is Vicki Keller, and I work for the HAI program, or the Healthcare Associated Infections program, part of the California Department of Public Health. And if I could see you all, I'm sure I'd recognize some of your faces. But in these times, I'm so glad that we could at least get together virtually. Thank you, CAHF, for inviting me to speak. I love talking to this group and entertaining any questions and just sharing our experience that we've had. CAHF has asked me to talk about our HAI program infection prevention assessments that we did at skilled nursing facilities at the onset of COVID-19, specifically in nursing facilities. So with that, thank you, and let's continue. So our objectives today, we're going to discuss specifically the process of our visits, the challenges that we faced when we were in the facilities and that the facilities themselves faced, and the recommendations that we made for COVID-19 assessments in skilled nursing facilities specifically. We're going to discuss the importance of engaging your administration and your skilled nursing medical director in these infection prevention endeavors, not just for COVID, but that another time. We're going to review outbreak cohort strategies, describe personal protective equipment or PPE that should be used specifically with COVID-19. We're going to review the importance of hand hygiene, as always, in every lecture that you've ever heard from me, but specifically with healthcare personnel screening as well. We're going to discuss the role of effective environmental cleaning, which really has been made known even more so to facilities since COVID. It's always been important, but especially now. And then we're going to discuss when to remove transmission-based precautions and return to work. And this is a question we get very often from infection preventionists, directors of nurses, on when can we remove isolation, or when can we have our people come back to work? So I think we have our work cut out for us here. So as we begin, the first slide here, I just want to tell you a little bit about our HAI program, a group of infection preventionists that I work with, and I'm the supervisor of several of them. The HAI program was established in 2010, actually a mandate, a law in California that said you will have an HAI program. At the same time, CDC gave funds to all 50 states for infection prevention. So it was very timely. And California chose to put those dollars to work, feet on the ground, if you will, and hired very experienced infection preventionists back in 2010. We have 10 now, and they're all certified in infection control. And that's what we call a CIC, Certified in Infection Control, which is more than just taking a course. They have to have been experienced in infection control and pass a quite comprehensive exam to get certified in infection control. And they get certified every 5 years. We provide infection prevention consultation and recommendations, not only to SNF, skilled nursing, but also to acute care hospitals, which originally is where that mandate came from, was for acute care hospitals. And we've expanded to skilled nursing as funding has come from CDC to our program. We provide consultation for dialysis centers, clinics, prisons, especially with COVID. And if you've read in the news, there's been quite a bit of COVID in the prisons, and also to shelters. And that was something that was new to us to go out and do. But you may recall a couple of years ago with the fires that were up north, there was a norovirus outbreak as a shelter. They were experienced in how to provide shelter for people that had been in disaster, but not how to prevent infection. And so our group got involved in that, wrote some procedures, worked with some of the disaster agencies, and we've been involved there as well. It's important to note that our program is non-regulatory. We are part of the Centers for Healthcare Quality in California, as is licensing and certification, but we're not part of LNC. They are the regulators, or there to enforce regulation, and we are there for consultation and there to provide education. So a little bit of a situation update or an overview. We know that community transmission of COVID-19 is widespread in California. That's a given now. Of course, at the time we began this last spring, it wasn't quite so much, but we know that it's out there now. COVID-19 infected healthcare personnel and visitors can introduce the virus into the long-term care facilities where residents we know are at increased risk, right? Our most vulnerable population. Generally, you don't find COVID just popping up in a skilled nursing. It's brought in most often from someone from the outside. We know that acute care hospitals can't accommodate all of COVID-19 infected patients, especially when they don't require that high level of care. They need to move on so that the higher level of care can be provided for those that need it. And we know that long-term care facilities must prepare for COVID-19 introduction and transmission, right? If you were fortunate enough not to have any COVID in your building, that's wonderful. You're doing a great job. But once it does arrive, how do you mitigate it? How do you handle it so that it doesn't become a full-on outbreak, right? Of course, bear in mind, one case is considered an outbreak, but you don't want any more than that, right? So how do you receive and provide care for those individuals safely to keep your residents safe and also your staff? So when we developed our tools for going out and doing assessments, we didn't reinvent the wheel. We used the elements that were provided by CDC. So a situation update on the facility, like I just gave you for the state. What strategies does the skilled nursing facility have in place already? Space, meaning what about their building? How are they set up? How are they cohorting their staff and also their supplies? And we're going to go into each of these elements now. So situation update. When we go into the facility, whether it's by phone before we go in, we may ask these questions. Most generally, that's how it happens if they have time to talk to us on the phone in the middle of an outbreak. But certainly by the time we get there, we ask them about their COVID testing status. Now, during this lecture, we're not going to get into all the changes that have happened over this past several months on testing. That's another whole lecture in itself. But what we want to know when we are first engaged with a facility is the number of residents with lab confirmed COVID-19. And we want to know both this round of testing and cumulatively how many they've had. But at the time we began this, it was pretty much how many of you had so far. They just found 1 or 2 or 3 or 5, and we want to know how many. The number of residents with pending, that's important. If you have 10 confirmed and you only have 30 residents in the facility and 20 are pending, as opposed to a facility with 230, that gives us perspective on the facility. The number of healthcare personnel or staff with confirmed COVID, and also the number of staff that's pending. Important things for us to know, not just to harass the facility, but it gives us a perspective and also your local public health. Then we're going to ask some facility information. We're going to want to know what is your current census, what is your status, and that helps us know how many more admissions you might be able to take if that happens. And we also want to know, is there a ventilator unit, a memory care, or dialysis residents in the facility? Because we know that those residents are at higher risk, and your situation is going to be a little different than places that don't have that high acuity within their building. And the final question we asked, one of a few, is there corporate ownership or management? And folks might wonder why that's important. Corporate ownership might imply that the facility has a little more support, right? Especially if there are other facilities in your area that are sister facilities where you can rely on for extra staffing or supplies should you need them, or just overall corporate support for infection prevention. It doesn't always happen that way, especially if one facility is in Northern California and another is up, down south. But in general, that helps. The next question we'll ask is there a full-time infection preventionist available on a daily basis? We have found, and you're going to get a lot of aggregate information from me, not specific numbers, but an aggregate, in that we have found that the most effective responses that we have seen, in other words, facilities that maybe had COVID come into their building and they were able to make it go away. And we'll get into that in a minute, but those were the facilities that were able to do that had a strong IP who was involved with COVID-19 response from the beginning, and they had a strong administrative structure. Meaning when I called that facility and I talked to the director of nurses or the administrator, that the IP was involved in that conversation. Those are the facilities that did the best. And this was early on. There were some facilities that were able to recognize that they had cases that got in their building, they were able to mitigate, and they were able to get it out of the building and kept it out. The second caveat to that is one, having a strong administrative support so that when that IP recognizes that additional education or supplies or resources need to be had, that they're able to get that and they have that good communication with their administrator. The other piece is ensuring that the skilled nursing medical director is involved. So we have seen everything from a medical director that is barely involved, maybe comes once a month and is, talks with administration and not very involved, to those that are very involved and are working with the IP to mitigate any COVID that should come into the building. So what we're saying is that if the IP doesn't feel strong enough or capable or have the communication skills to deal directly with their medical director, they should have that relationship with administration to be able to get the medical director involved in COVID-19 prevention. So what did we find out? As we go through this, we're going to discuss the challenges that we've had and then the recommendations that we made as we move through each of these elements. So in the situation update, the challenge we found very often, and was really not a surprise from the work we've done with skilled nursing, is that the IP was previously the director of staff development, right? Was the DSD, and it was a new role for them. And they were maybe part-time staff, part-time DSD. They dabbled in infection prevention, and I don't mean that in a critical way. It's just that pretty much they reported if there was UTI or they reported any respiratory infections, that kind of thing. What we found is they were new to their role, and this whole infection prevention thing was new to them and they weren't trained. So our recommendation was that they have to be full-time, which since the time of our first involvement with nursing homes with skilled nursing has now become a rule. You have to have a full-time IP that has completed an infection preventionist training course. And we have the asterisk on the slide here to show at the bottom that CDC does provide a course that is roughly, I believe, 19 CEUs. You can get CEUs from the BRN for that course. And the information on where that's required is in the AFL that you see there, AFL 2052 with the link. So we know that full-time person, and we know that they have to be qualified and trained. I will let you know that our HAI program, many of you have attended our 2-day class, and that will be out as an online course, hopefully by the end of this year in November, by the end of November. The next strategy is screening healthcare personnel prior to the start of the shift. The challenge was that some SNF are using a sign-in sheet or some type of attestation. And we'll find out that they have COVID rampant in their building. They're really not screening healthcare providers before they come to work. Or they weren't asking. They would say, do you have symptoms? But they wouldn't list what those specific symptoms were. The recommendation, of course, came from CDC, and this is the quote from CDC, that they have to actively take temperature and document absence of symptoms for COVID-19 on every healthcare provider. And that's for all shifts, not just day shift. Perform hand hygiene when they enter the building and put a mask on. They should have already been wearing a mask, right? At least a cloth mask outside the building, and upon entering the building, wear the medical face mask that's required. And of course, educate your staff not to come to work sick. I think sometimes people think they need to come to work sick to prove to their supervisors that, yes, indeed, I really was sick, but educate them not to come to work sick. And if they get sick while they're at work, to notify their supervisor immediately. And all of this is in the CDC guidance that you see at the bottom of the slide. We have seen staff come to work sick, thinking they're going to get in trouble if they call in sick. They will take some Tylenol before they come in so they won't have a fever. It's important for you to train your staff not to do that, because that's how it gets in the building and that's how residents get sick. This is an excellent slide from the CDC that you'll see on your screen in a second here. Know the symptoms of COVID-19, which can include the following. So it's important that they know what the symptoms are: cough, shortness of breath, fever and chills, muscle or body aches, vomiting, diarrhea, and the newest one was loss of smell or taste. Print these out, laminate them, and put them throughout the building so that your staff know what the symptoms are, right? So they won't come to work, they'll call and ask. Sometimes with seasonal allergies, you may need to make a judgment call on whether they're really sick or if it's an allergy, and that is something you need to work out within your facility and possibly with your local public health. You don't want people that are sick coming to work. So the next strategy, we'll talk about what are the strategies to keep it out of your building. We talked about situation, strategy. All healthcare personnel wear a face mask, social distancing at all times. And that is what we look for when we go in a building. The challenge was, they'll tell us, oh yeah, we have social distancing and they're obeying it at our facility. And then when we go and do our rounds, we'll look at the break room and see all the evidence of a potluck with a lot of chairs in there, meaning there were people in there sitting and eating and enjoying, and they love to be with each other. They love to congregate. But very often an outbreak begins with multiple healthcare personnel bringing it in before any resident ever tests positive. And so these are some of the things that we want to make sure that the challenges that skilled nursing are addressing. So what do we recommend? Well, convert any unused dining areas, because you're not having congregate dining, right? Or any break areas. Make sure that you have socially distanced the tables so they're far enough apart. You know, if they're 6 feet apart, they can talk to each other 6 feet apart and still talk. Or if you can't do that, stagger break time so that people aren't all going at the same time. Educate your staff on social distancing at work, but also in the community. When they leave work and they're going to parties, and we'll talk about that a little bit later, or other engagement, that's where they're getting COVID, and then they're bringing it in unknowingly into the skilled nursing facility. So it's really important that you are recommending that for them as well. Another strategy is to limit the resident movement outside of their room. This is a hard one because we observe residents mingling outside the room without face masks, even during an outbreak, and staff were letting them do that. And so it takes a lot of frequent reminders to remind your residents to stay in their room, to wear their face masks. You know, they may not remember. They may not want to hear it from you. Maybe they need to hear it from their MD, and maybe they'll listen to their physician because maybe they've known them for a lot of years and trust what he or she has to say. And of course, by now you've already suspended group activities. Create ways to engage with social distancing and masking. There's ways of doing games where people aren't right near each other. And of course, implement any additional strategies for memory care units. And there's a link there. And on the next slide, I'm going to show you something that we just put on our website. It's called the COVID-19 Memory Care Unit Reference Sheet, and there's a link to it at the bottom of the slide. But really, we know that COVID-19 prevention and mitigation strategies are difficult to implement in the memory care setting. So you can consult with us. The CDC, as I showed you on the previous slide, has a link. This is our link to help you face the challenges with memory care units. We have seen big outbreaks come as a result of being unable to manage memory care residents mingling throughout the facility. So it's a special burden that you have in those type of facilities, and we recognize the challenge that you face there. Another strategy is restricting non-essential visitors, which all facilities have done this by now. In the beginning, when we were doing our assessments, it was not quite as prevalent. But of course, the challenge was screening essential visitors at the entrance. So people were screening staff as they came in, but maybe the screener was gone after the change of shift. So essential visitors weren't being screened, and they need to be. The terrible problem with resident loneliness and depression, and we hear that on the calls. Those of you that have joined our calls, we hear that, and we know that some visiting has been allowed back in some facilities throughout the state, and I won't get into the specifics of that today because that's an ongoing thing. It's evolving, but we know that families are concerned about their loved ones' well-being, not being able to be there. I haven't even been able to hug my own mom. She's not in a skilled nursing, but we refrain from hugging or signs of affection because I don't want her to get sick. And of course, there's end-of-life concerns. If someone is a hospice resident, you know, what extra can you do to facilitate some type of visitation but keep everyone safe? Right? So we recommend that the screeners at the door at all times, that the masks and hand hygiene are available for those visitors. Remote communication, a lot of places have done that with video calls and tablets, large windows where people can visit and at least see each other and touch at least up to the window. Or some places, I've actually seen this, are placing their hospice resident in rooms near the entrance so that when visitors do come, they're not walking through the entire facility. Now, at the bottom of this slide is a link. And it's the I'll refer you to the most recent version of AFL 2022. At the time of this recording, there is a new AFL that will be coming out, and it will still be on this link, where the CDPH will be updating visitor requirements. So that is a live link and it will take you there. So watch for that in the upcoming weeks, maybe even by the time this is seen at your venue. So watch for that. To find that, you can just Google AFL 2020 CDPH or CDPH AFL 2020, and it'll take you to all our all facilities letters. So now let's talk about surveillance. Now, surveillance daily or more frequently is monitoring for fever, cough, shortness of breath for all residents, all, regardless of their status, and monitoring vital signs, including pulse oximetry every shift for all residents. And we recommend every 4 hours for COVID positive residents. And I get the question all the time, where does it say I have to do this? There's no have to do this that is written anywhere, but we recommend it from CDPH. And I'll tell you that facilities that had an outbreak that got away from them will say that, you know, everyone was normal, but the first thing we saw before they got ill, let's say they were asymptomatic, was the pulse oximeter went down. And then they got sick. So if they hadn't been watching the pulse oximeter, they wouldn't have the early information that they would need to be watching for that. So pulse oximetry is very important. And of course, you want to track all suspected and confirmed respiratory infections using a line list. And we'll get into a line list. It's more than just listing those with a respiratory infection, but you want to be aware of all respiratory, right? Because you're still watching for other kinds of pneumonia. You don't want to forget that we still have Legionnaire out there, right? Legionella is still out there. So you have to watch for other things as well. You're balancing a lot of plates as you are becoming your infection preventionist in your facility, or as an administrator if you're managing that. So what are the challenges with surveillance? Skilled nursing was not familiar with the importance of a line list. Most skilled nursing just kept a list of who had a UTI or who had a respiratory infection, and that was pretty much it. Maybe scabies, right? Maybe scabies. And it's not just a list of COVID-19 positive residents either, not just a list. And it's not just your, as I said, your respiratory infections. I'm going to show you in a moment that you're going to create a line list with the first round of testing, which most of you should have done that already, had your first line of testing. And it really establishes a baseline and your ability and our ability and public health's ability to help you track the spread in your facility and to help mitigate. So this is a sample. I'm going to show you a couple of them here. This is just a template, and it has since been updated a little bit, and you can get this at the email address that's down below. It will soon be on our website for resident. And you'll note in the upper left-hand corner, it says facility name, and then the date of the summary. And in the red box, what is your cumulative total of residents that were positive, negative, or pending, right? Just the total number. And then in the light blue box, the number for round testing number 1, round number 2, round number 3, because you're probably doing it weekly by now. And you would be doing it weekly in an outbreak, right? Down lower under the big blue bar there, you're going to list the names of all your residents, not just those that were positive, and not just those that were tested, although you would have tested all of them. You want the name of all residents. And then where it's circled in red there, the date, was it positive or was it negative? Not just the positive, we want to know positive and negative. And then the next box would be, that was your baseline testing. The next red box you see there would be the next round of testing that you did. Now, in an outbreak situation, you would be doing it every week. If you have no COVID in your building, you wouldn't be doing it every week because you would just be testing your staff if need be. But for your residents, if you're in an outbreak situation, we want to know the initial round of testing, and then the advantage of having all your residents listed at the left is that you can follow along with initial testing round number 1, to go to the right, testing round number 2, and follow where they were located at the time of their positive test. This helps local public health and us help track how it's being tracked throughout your facility. In the next slide, we'll talk about how we do that with staff. Very similarly, for the staff, we're going to do the same thing. You have the name of the facility, the cumulative total, the baseline, and the testing round number 1, 2, and 3. And again, on line 11, you see here that you would put the last and first name of the staff, what their title is. That's very important. Is this a CNA that only works on one wing or one floor of your facility? Or is this a physical therapist who goes all over the building? You can see where that would be very important to know if it's a physical therapist going all over the building. Because who knows who they might have contaminated, right, or exposed if they did become COVID positive. So again, it's really important to have one for resident, one for staff. Some people have submitted these with all the positive on one sheet, all the negative on another sheet. You're working too hard if you're doing that. You put them all on one sheet with their positive or negative results. And we have help for this for you if you need more help with it. Now, the next question comes up is, how do I use this? This is just people that are harassing me, that are trying to get numbers from me, and I don't have time for this. How is this going to help me? In the next slide, I'm going to show you how those data are used to show the facility, to show the county, the state, or even your administrator what has happened in your facility. So what can the line list tell us? So in this skilled nursing A, on the bottom, the blue are the healthcare providers, the workers, and the red is the residents. And on the left, it tells you the number of positives. And just quickly, I'll say here, there's a date range there because not everyone got tested on the same day. But you can see we had one healthcare provider that was positive. And the next round of testing, there were another four that were positive. No residents yet, right? No residents were tested, but none were positive. And then we get into the first week in June. Oh, we have 3 more staff, but now we have 6 residents. Look what happened by the fourth week, June 4th, 12th through the 19th. All of a sudden, boom, that's the tip of to the left was the tip of the iceberg. To the right was the rest of the iceberg. So when you have asymptomatic residents in there, you can have asymptomatic residents that are shedding and you don't know it. So the residents could be positive and we don't know it. Again, why it's so important that we have universal masking, hand hygiene, and social distancing within our facilities. So this is a case. The next slide tells us a little bit something different. In this slide, I want you to walk through with me. The blue is the staff and the orange is the residents. And you can see in the beginning, we had 1 staff and 1 resident that were positive. The following week, a few more residents. The following week, a few more residents. Staff and residents are going up by the 3rd round of testing, right? And we get into July 2nd, which is the 1, 2, 3, the 4th round of testing. We have more staff than we have residents that are positive. Oh, good. Then July 7th comes. No residents were positive, but look how many staff were positive. Look what happened by July 15th. Boom, it blossomed. We have several staff, probably 12 staff that one testing that tested positive. We know that COVID has a 2-week incubation period, right? So if you're looking at that slide, you'll see that on July 15th, we had all these staff that were positive. If we go back 2 weeks, that was July 4th weekend. What do you think happened July 4th weekend that within 2 weeks we have that many staff positive? 4th of July parties, barbecues, whatever. But again, we have that many more staff that are positive that are coming to work. It's being brought in by our staff on the outside. And we found this early on. The other part of that's just interesting, right? Another part of surveillance is making sure that you have a procedure to notify other facilities prior to transferring that they do have COVID or that they're suspected of COVID, and that always notify your local public health for any of this. Notify your local public health. And this is where the form can be found on our website. Now let's talk about space. Space meaning your designated areas, whatever room, wing, or unit that you have designated, one for your positive residents, which is now being called the green zone, right? The red zone, Your positive COVID-19 or the red zone residents. An area for persons with known exposure, that would be your yellow zone. COVID-19 negative, meaning they have been tested, they're negative, they've never been exposed, or they're recovered. They were positive, they've been treated, they're over it now, and they're recovered, and they would be in what we would call your green zone. And then you have your observation unit, and a lot of people confuse that with your yellow zone. Your yellow zone are exposed residents. Your observation are unknown exposure, right? Unknown exposure. It's important that you understand the difference. And I would say most people understand the red zone and they seem to understand the green zone. They get confused in the yellow zone. We're going to explain that in the next few slides. So let's talk about the COVID positive. That's pretty straightforward, right? That's your red zone. These are private rooms, if possible, with the door closed, if it's safe to do so. And there's more discussion on that, but if it's safe to do so. If it's unsafe, you can't make a blanket statement that, well, it's unsafe for all our residents. We have to leave all the doors open. Facilities have been cited for that. I'm not regulatory, but I've heard that. So you have to have a rationale for that door being left open. If you have to put two residents in the same room, you want to cohort them with the same diagnoses and not just COVID-19. Yes, of course, they're positive for COVID-19, but you want to make sure there's nothing else going on. You wouldn't want to put someone, for example, with C. difficile in the room with someone that does not have C. difficile, even if they both have COVID, right? That seems like a no-brainer, but we don't want to forget that there are other infections that are happening at the time. And you don't want them sharing a shower with other non-COVID residents either. So the red zone or the COVID positive have to have their own shower. And if you have to resort to sponge baths for the 2 weeks or so that they are in isolation or in transmission precautions, then you may have to do that, but they have to have their own shower. At the same time, you want to cohort designated staff to care for your COVID-19 residents only, meaning that the staff have their own entrance and exit. The entrance isn't as important as the exit when they've been working with COVID positive residents all day. And they want to have their own restroom and break room, because you don't want them commingling with other staff that are caring for your green zone, right? No commingling. That is where we get into some issues, and I'll talk to you more about recommendations as we get through each of these cohorts. So we've discussed the red zone. Let's move on to the exposed residents, or the yellow zone. So the exposed residents, again, a private room if possible, and we know that that's premium. We don't always have that, a non-shared room, but they have to share a room. You want to, now these are exposed, this is important. They're exposed, but we don't know if they're COVID positive yet. That's where people get misunderstanding. They're treating them as if they're all positive, and they might not be. You don't want someone that's been exposed that is COVID positive to be exposing someone that may never become COVID positive. So you want to keep the privacy curtain between the beds closed, even though they're both in the yellow zone. Keep the privacy curtain closed, maintain 6 feet distance between beds, and of course, universal masking with those residents to try to keep them from exposing each other. One may become COVID positive, the other one might not. Again, if they're in the same room, make sure that you're not putting a resident with CDI in with a non-CDI resident, just as we explained before. And you want to cohort designated staff who care for COVID-19 exposed residents if possible. It's not always possible. So we'll get into that in a moment when we talk about PPE and staffing. But if you can keep your staff cohorted red and in red, yellow and yellow, and green and green, that's the best if you can do that. It's not always possible. We understand that. COVID-19 negative, or you're unexposed, or those that have recovered, of course, you're going to have universal masking and enhanced standard precautions. Enhanced standard precautions mean you're going to wear PPE when you are performing those type of activities that might splash, right? Staff should not be caring for COVID positive or exposed residents. So if you're in this green zone, you should not be caring for residents that are in red or yellow. In green, you want to keep them that way. You might have recovered residents in there, which would be at some point considered somewhat immune, but especially those that have never had COVID, you want to keep it that way. So let's talk about your observation unit. And this area gets very confusing to people. They confuse it with the yellow zone. Your observation are those that have been, you don't know if they've been exposed. It's an unknown exposure. They are new admissions. They should be tested prior to admission, but if not, then you should test them as soon as they arrive. They should have, again, a private room if possible. And if they're sharing a room, again, just like in the yellow zone, you want to have a privacy curtain between them, maintain 6 feet social distancing and universal masking. Remain in observation. They remain there for 14 days from the last potential exposure, which is the incubation time, and then they get retested at 14 days. Now, you got to keep them there till you get the results back. If they're negative, then they can go to the negative area or your green area. And if they're positive, they're going to go to the red area, right? Okay. That's your observation. The challenge is getting staff to understand the difference between yellow and observation, right? These are people that have not been exposed. And the challenge is getting them to understand the reason that staff aren't supposed to commingle, that we see residents that were wandering. It sounds like it's willy-nilly, but it wasn't so much. But these are things we observed while we were there. And then staff that are assigned to both COVID positive and negative areas. We've seen that. We know that not enough staff, in some places there weren't enough staff to create all three cohorts. So what did we recommend? We always cohort COVID-19 positive residents with staff, as I said, and the negative residents and staff, right? Keep those two separate from everyone else. If you're short staff, you might want to consider the same staff for your COVID exposed and your observation area. But again, this is an area where they have to really be trained to understand what they're doing with donning and doffing and hand hygiene, so that you're not accidentally exposing a resident to COVID that was exposed, but maybe didn't get it. And you don't want to give it to them while they're with you. Exactly, right? So again, the yellow area is the tricky area, and that's where you want to really it's all important for education, but this is the area where there's a lot of confusion for your staff. This is an example, and you may see this coming from us in this next slide coming up, is we may ask for a map of your facility, and you think, well, why do you want a map? You should have a map available in your mitigation plan, as well as once we're discussing an outbreak with you. This is just an example. This facility showed us in red where their residents would be coming in to the red zone, and where staff would be entering, and the yellow zone and green. And it was an excellent way of showing us and their local public health and how they were going to handle surge capacity should they get more COVID positive residents. Anytime you can have a map, it's very helpful. It's one of the first things we ask for. Now a topic that's near and dear to my heart, and we'll talk about cleaning and disinfection, which is always important, not just for COVID, may I say this, not just for COVID, but especially in times of having an outbreak. And the first one here, we use an EPA registered healthcare grade disinfection and a label claim for COVID-19. And there's a link at the bottom, and it's the EPA list N, and it tells you which disinfectants are approved for COVID-19. We want to make sure that the facilities are cleaning the high-touch surfaces frequently. Some places have gone to even having a full-time person just going through the facility every 2 hours, making sure they clean high-touch surfaces in either residents' rooms, the break rooms, the work areas, the hallways. Cleaning shared resident equipment's important between residents. And of course, making sure that the disinfectant bottles are labeled with the wet time. That's the time that it needs to stay wet, or it's called the dwell time or kill time, to make sure that it is killing the bacteria. If you don't, or virus, if you don't leave it on long enough, it's ineffective. You want to make sure that your cleaning staff don and doff PPE appropriately, and that the cleaning staff are they're cohorted the same as your nursing staff are for the COVID-19 areas, whether it's red, green, or yellow. And of course, that they're proceeding from clean to dirty, and I'll talk about that in the next slide. So here's the challenge that we found in going into facilities. The challenge was the cleaning staff were not donning and doffing correctly, especially in doffing. They would contaminate themselves, or they wouldn't wash their hands once they've taken the PPE off. They weren't adhering to the wet times of probably in a hurry to get things cleaned, or the cleaning staff were going, and we did see this, from a positive COVID area to other resident areas within the facility. So a lot of teaching and recommendations were here, that the PPE training is done at your facility, but with a return demonstration. Have them watch. I've actually done it with FaceTime. I've watched people don and doff PPE, and I have been able to critique over the phone, and your public health might do that with you as well. Educate them on why it's important for the kill time, that just wiping it isn't going to do it. And cohort your cleaning staff just like you would your nursing staff, right? So if your cleaning staff is limited, and often that is the case, train them to clean the non-COVID areas first, like your green areas first, and then move to the yellow and dirty areas or red areas at the end. And then, of course, do adherence monitoring. And there's a link there to tools we have. So as an IP, you can observe them doing their cleaning. Now, often in facilities, I'll hear this very often, is that we contract with an outside provider and they do all that. That's a cop-out. Yes, they may do it, Maybe they don't, but it is the responsibility of you at the facility, especially as the infection preventionist and certainly your administrator, trusting you to do this, that they are doing the right thing, that it's not only in their policies, but that you're watching to make sure that they've been trained and that they are doing the right thing. So involve your supervisor when you're doing rounds to watch this, and very often it's an eye opener for them as well. So let's get into supplies. Boy, this was a big one when we first started with COVID. Not as much now, but it is still an issue, and I'll explain why in a minute. They have to be aware of how many face masks, how much eye protection they have, including goggles and face shields. And I will say right here that eye protection, if you wear eyeglasses, that is not eye protection, prescription eyeglasses. You have to have goggles or face shield over that. And 95 respirators, gowns, gloves, and also making sure that you have enough alcohol-based hand rub. And I'll show you some more on that. Give you some tools to help you. So this is the challenge with supplies. The skilled nursing was not aware of their PPE usage. Oh yeah, they would say, well, we have plenty, we have plenty. They didn't anticipate the increase in usage with COVID-19 suspected or positive residents. In other words, we have no COVID, we're good, but they didn't anticipate, well, gee, if we get one, do I have enough PPE? And that's what would happen. Like on a Wednesday or Thursday, their testing would come back and they'd find out we have 4 positives. Now what do? We don't have enough PPE, or they didn't anticipate it. I'm going to show you in a minute how to use the CDC burn calculator to help with that. And for extreme shortages, of course, contact local public health. They're there to help you get supplies. The Medical Health Operational Area Coordination, or you hear the term MOOC, is there with emergency supplies to help. If you review AFL 2039, that talks about optimizing the use of PPE for extending the use of PPE. And you'll note that I crossed off here AFL guidance for decontamination or reuse. CAHF has come forward and said, no, you cannot reuse PPE. That was their edict, only in the event of extreme emergency. So one caveat I'll say here is that OSHA has said you can continue to send the N95s in to be decontaminated, but you can't use them when they get back. You can put them away in case there's a surge and we have no more PPE, then you can reuse them, but only in that case. That's important to know. So I left that there. In the next slide, CDC, and the link to it is in this slide, is the CDC PPE burn calculator. And I won't go into this because it's quite simple to use, but basically says how many COVID or COVID residents do you have? That's the number 20 you see there. And then you go down and say, how many gloves do we have? How many gowns do we have? How many respirators? And you do that each day, and it will calculate for you how many days supply you have. Important to know. Next slide. Just a tool that's available for you. What kind of PPE should I wear? So right up front, I put the 2 easy ones. There's the COVID positive, which we call the red zone, and the COVID negative exposure recovered. So the COVID positive is a N95 respirator, eye protection, goggles, gown, and gloves, right? And of course, hand hygiene. In the green zone, universal masking, enhanced standard precaution, PPE is required for the test, depending on the use, standard precautions, enhanced standard precautions. In the next slide, we'll go on to our yellow zone, and that's your exposed. Remember, yellow, they've been exposed. You have to treat exposed as if they have COVID as far as your PPE is concerned. Again, N95, eye protection, gowns and gloves. In your observation, once again, you don't know if they've been exposed, so you have to treat each resident as though they might be. And your N95 respirator, eye protection, gowns and gloves with hand hygiene in between. That's pretty simple. That's why we put it in a chart like this. In the next slide, we talk about the challenges that we found. People donning and doffing incorrectly, contaminating themselves. This is why it's so important that you educate your staff upon hire annually, that you do just-in-time teaching, that you're using the adherence monitoring tools that I'm going to show you in a minute, and you use some excellent education tools that CDC has out for training, which I believe will be in the next slide. At times, they will get tired of listening to you. They did me when I was working in my facility, and it's nice to have some videos or some other things that you can show or other ways of educating your staff, and I believe that's in the next slide, if I recall. Yes, yes. These are links to the CDC website, and if the link doesn't work, you can just Google CDC using personal protective equipment. But there's a video on how to put it on, how to take it off. There's some fact sheets, some posters that are available to you, and lots of illustrations. Use those tools. They're available to you. And as an IP, you want to make sure that you use everything that is available to you, and CDC is there to help you, as are we at CDPH. In the next slide, this is OSHA's, Cal-OSHA. Now, you know OSHA is the federal government protecting employees, right? Their standards are there to protect employees. Cal-OSHA is there to keep the healthcare worker safe, right? And they provide information, and this is called the, what we call the ATD standard, aerosol transmitted disease standards. And that's the one where we find that says we have to be fit tested for N95 respirators, even in nursing homes. So what do they say specifically? In the respiratory, you have to have a respiratory infection program. All Californias, all facilities, including SNFs, are required to care for residents with some type of transmissible infections, and they have to have a respiratory protection program. That was even before COVID. You have to have a program that ensures that your staff have been fit tested within the last year if they're going to be wearing an N95 mask. Now, they lifted that every year requirement during the outbreak because we were running short of masks. Or respirators. But if you don't have a respiratory protection program, you need to develop one immediately. And you probably already do in your mitigation plan, but if not, contact your local public health or our program and we'll help you with that. How does staff get fit tested? That's a question that comes up often. Contact the manufacturer of your N95 respirator. They may have a way of getting a kit, but if not, you can purchase a kit possibly through one of your providers like Medline or McKesson. 3M has a kit. There's a link there. When you go on their website and want to get the fit testing, you want to make sure that you are asking for a qualitative testing process. The other thing you can do is contact your local public health department, because even in your area, there might be something that's going on with the hospitals or in your area where local public health can help, or contact your hospitals in your area. You know, it behooves them to have you ready to accept residents in your facility, right? It's been very successful in skilled nursing that have a good rapport with their acute care hospitals. Many of the acute care hospitals have fit tested those that are in the skilled nursing. What is a seal check? That's the thing that comes up next. Now, the N95 respirator seal check is not fit testing. The seal check should be done anytime you put on an N95 respirator, whether you've been fit tested or not. Even if you've been fit tested, you need to do it. And basically, there's instructions for a seal check right here at this link. And you can Google OSHA instructions for seal check. It's all over the internet. This particular link has a great poster for that. But basically, you're checking after you put it on properly to make sure when you inhale and exhale through your mouth that you can suck the mask in or blow it out, and there's no leaks on the sides of it. And then you would readjust your straps. So that's how you do that. Cal-OSHA now, this is a new slide, has some interim guidance. Remember I said you can't reuse anymore? But they have said that you can use extended use, meaning you can leave an N95 respirator on throughout the day, all day for your shift, 8 to 12 hours, leave it on, and just take it off during breaks, and that's called extended use. And it shouldn't be donned or doffed more than 4 to 5 times a day. So that gives you a chance to take it off for your breaks, be able to breathe. But when you take it off, it should be stored in a breathable container, like a paper bag. Make sure your name is on it when you go for your break. Now, the last bullet point's important here. Used respirators can be stored and labeled for use only in a crisis. And what we're finding is when you do your daily report of how much PPE you have, people are saying, yes, our PPE is good, but they're reusing or redonning PPE, not just N95 respirators. If you're reusing, redonning, extended use, it means you don't have enough. And you have to reflect that in your reports that you give each day. So used respirators can't be reused. Here's what we found with PPE usage when we were out as far as a challenge. Improper implementation of the conservation strategy. So they have plenty of PPE, but they're reusing or using extended use. They had residents with discordant MDRO status. What does that mean? Maybe putting a CDI resident in with a non-CDI resident because they were trying to conserve PPE for whatever reason. They were sharing a room, or wearing gowns in hallways. They have the assumption that because they are in the red zone that they can just use extended use of a gown, which is okay, but they were using it and wearing it out into the nurses station, which is something that shouldn't happen. Yes, you're in a red zone, but the nurses station is kind of still considered a clean area. You don't want to be wearing your gown out into the nurses station. There was a lot of confusion around that. So the preferred gown conservation strategy is in the exposed or in your observation areas if you're conserving, to use enhanced standard precaution, which means if you're just going in to drop off a tray or a medication in the exposed or in the observation areas, that you wouldn't need full-on gown for that. Gloves, possibly. Oh, well, gloves always, but a gown only if you're going to be worried about being exposed. That's the preferred method. And of course, residents with different MDRO must be isolated separately, as we've said, and gown only worn in the residence rooms. So that's what we saw. And we think that that's increased the exposure to CRS. We're seeing more CRS and other MDROs because of some of this reuse. Now, a little bit on taking residents out of transmission-based precautions. We no longer use what was called the test-based strategy. We use symptom-based, meaning if your resident had mild to moderate illness and they're not immunocompromised, they have to be at least 10 days past the onset of symptoms, and no fever for 24 hours without a fever-reducing medication, and the symptoms are improving. And if that's the case, they can be removed from transmission-based precautions and put into the green zone. And that's in AFL 2053 at the bottom of the page. In the next slide, we discuss those residents that were asymptomatic. So a positive test came and they have no symptoms. So we've got them in isolation, but when can we take them out? Again, at least 10 days have passed since the positive test, right? And symptoms, and the symptoms have improved. Well, excuse me, I misspoke. They have to have at least 10 days past the positive test. If symptoms do develop, then you switch them over to the symptom-based strategy and the clock would start over again from the date of symptoms. In the next slide, we talk about your residents that had severe illness. Now, of course, they went to an acute care hospital by then, and they may be better, but they're severely immunocompromised or they're severely ill. They will need at least 20 days past onset of symptoms and at least 24 hours without fever or without medicine for fever, and the symptoms have improved. Now, here you may have a difference in your local public health. They may want it longer, and if that's the case, you need to go with the more strict. With anything I've talked about today, if your local public health has a more strict policy, that is the one you need to follow, more strict. Now we'll talk about the staff. What about your staff that gets sick? What do we do with them? It's actually the same. We no longer look at test-based strategy in general. We look at the mild to moderate illness, those that have symptoms, they're not immunocompromised, and they have at least 10 days that have passed since the first symptom, no fever for 24 hours without medication for fever, and their symptoms have improved. Now, if you have healthcare personnel that are not severely immunocompromised and they're asymptomatic, again, you would go back to the date of the diagnostic test, just like you did with your residents, and you would say, okay, 10 days past the diagnostic test, they're not immunocompromised, no fever, then they could be returned back to work. What about the healthcare personnel that had a severe illness? And we've had some, unfortunately, that were severe or they were severely immunocompromised. Again, they need to be out at least 20 days, longer if your local public health says longer, and 20 days since the first symptom, at least 24 hours without fever and without medicine, and the fever symptoms have improved. Now, healthcare personnel that are severely immunocompromised but are asymptomatic can return to work when 20 days have passed from the date of their first diagnostic test, the same as with your residents. I think that covers this for our staff. So what about, this question comes out, what about positive healthcare personnel returning to work? So in a crisis strategy, you have a worker who tests positive, but they have no symptoms. They actually can come back to work as long as they meet the criteria. They can only care for residents that are confirmed positive because they're not going to give that resident COVID, right? They have to maintain separation from other healthcare personnel, meaning very strict about entrance into the building, exit, break room, restroom, and they may not care for residents who have not tested positive until at least 10 days after their own test has come back negative. So that's important, and that's in the AFL you see at the bottom of the slide. And I think with that, in summary, really, we have seen facilities that you can get through this. We have seen facilities who have been able to get it out of their building, but it took a lot of work. It took a lot of communication with their staff, and a lot of open and honesty with their staff, and a strong IP presence. An engaged administrator and an involved medical director will ensure better outcomes. Your healthcare personnel screening prior to entering the building is the way you're going to keep it out, and training your staff to recognize when they have symptoms. Strict cohorting of your residents and staff will also reduce transmission, and adhering to it, I know it's tough. Proper selection and use of PPE will protect both residents and staff. And again, not only proper selection, but proper use, donning and doffing and hand hygiene. And of course, knowing when to discontinue this transmission-based precautions and returning to work really will improve the morale for both the staff and for your residents. With that, I'd like to say thank you for allowing me to have this time with you, and I wish you all the best in your COVID mitigation and prevention. Thank you.